Okay. Hi, everyone. I want to thank Dr. Fraser for the introduction. I was going to thank Ashley for the introduction, but you are also thanked for inviting me to speak at this conference. It is an honor to be here. It is my first family conference. It's going to be fun. And then, as Dr. Fraser said, I joined the White Matter Clinic 2.5 years ago because of her persistence in asking for a palliative care physician to see their patients. And honestly, a blessing and a privilege to get to know families longitudinally because we don't always get to do that in palliative care. So my intention here is to, wait, there we go. Okay. Is to introduce palliative care for patients with LCC, to discuss what it is just globally and how it can be helpful. And it's a very big picture overview because palliative care is for children especially, and even adults, is a newer field. And so it can be very different at every institution. I am a pediatric palliative care physician, so I will often refer to patients as children. But the concepts and also many of the available resources and the general overview, while they vary by institution, most of them apply to adults as well. Did I forget anything? No. Okay, great. So I want to start with defining palliative care. This is a definition that's written by a physician. There will also be another one written by a video of family members. It's typically for patients with a life-threatening or life-limiting illness. So progressive neurological disorder can fit this category. And we've learned a lot about all the different symptoms and the way that LCC can affect people's lives. So it's defined as an active and total approach to care from the point of diagnosis or recognition throughout the child's, adult's life, death, and beyond. It embraces physical, emotional, social, and spiritual elements and focuses on the enhancement of the quality of life, it's a big word, for the child or young person and support for the family, and includes the management of distressing symptoms and provision of short breaks and care through death and bereavement. So that's a lot of words. What actually does that mean? So really the goal is to add a level of support and care, not to take things away, which is what sometimes people hear palliative care and they think we're getting rid of everything else. The focus is on the whole person. So that's where the physical, emotional, social, and spiritual elements come in. And it's throughout the trajectory of the disease and even after death to support the family in their grief. And quality of life, as anyone who's a human being knows, quality of life has many different components to it. So we try to incorporate all of that. So that was a definition from a physician. This is perspective of a family of a child with leukodystrophy on including palliative care in their child's care. And I also want to call attention to this organization, and I might have to, let's see in a second, from which I got a couple of videos from them. This is called the Courageous Parents Network. And I think some of you guys who I've met in clinic, I've introduced NeuroJourney to, but it's a website and organization that has a wide range of digital resources and programming to help caregivers navigate care of a child with a serious illness, from initial diagnosis all the way to coping with loss. Let's see. Nope. Do you mind clicking the play button for me? It should be in the center of the video, or it disappeared. Okay, that was a family who's describing their experience being introduced to palliative care and how it wasn't just about end of life, but it was really about focusing on the quality of life for their child and helping their child thrive throughout the course of their life, no matter how long it is, whether it's 5 years, 10 years, 20 years, even longer. I promise I tried to put in parent perspectives. Okay, so when can palliative care be helpful? Where's my light? There we go. Don't block the light with your finger is the most important thing. Like I talked about, it's the beginning of, we like to introduce palliative care early at the presentation or initial diagnosis, and then it can continue all the way until end of life. And that there's no timeline here. This can be whatever timeline. And then we support families even afterwards with bereavement. What's important is that it can be given at the same time as therapy to modify diseases. So the big focus of this conference is learning how do we move therapeutic interventions, disease-directed interventions forward, right? That does not preclude receiving palliative care, and I think that's really important. Another thing is sometimes are crushing it. I don't need to come in and do a lot of interventions. I can step back. And so there are periods of more or less involvement of palliative care, depending on the disease course and the impact on quality of life. But the purpose is really to promote early introduction of palliative care to help with that quality of life throughout the course of disease. There we go. Okay. I really like analogies because I think palliative care can be a scary word. And so I like to demystify a little bit. This is a comic. I think it's a helpful analogy. It was written for patients with advanced cancer, but I think it really applies. So in this analogy, Palliative care is the umbrella, and the symptoms and the effects of the disease on quality of life that have been described beautifully by Dr. Harmon and Bree and all the other presentations, that's the RAIN. And so if you have, this is late palliative care, and so the patient and their family are experiencing the effects of the RAIN and the effects on quality of life, and then the umbrella comes in and is provided later, and it's still helpful, but they've already experienced a lot of the effects of the disease. And the early palliative care referral essentially is giving them the umbrella earlier. And so it doesn't keep you from getting wet. It doesn't make the disease go away. It doesn't change the whole process, but hopefully it can mitigate a lot of the changes to quality of life and provide some support. So what does pediatric palliative care entail? More details. So there's a clinical team, and the clinical team is typically physicians, case management, nurses, PT/OT, speech therapy, etc. A lot of that clinical team works or is the team that is doing assessments and providing therapy for your child anyway for their disease-directed therapy. Then we have a psychosocial support team, and that's the part that's really unique to palliative care and integral to palliative care. And that's where social work, pastoral care, chaplaincy, expressive therapies, child life, especially in the pediatrics realm, come in. It can be delivered anywhere in the healthcare continuum. And then really the things that we're really trained and expert in are communication, which we know can be a challenge in many of these situations, decision-making, and we'll go into some details of this, goals of care discussions, and then symptom management and psychosocial support. And we work closely with the other team members to help navigate this. And the psychosocial support, importantly, is for the whole patient. It's for the patient and their whole family, not just the patient. And so I love that Dr. Harmon mentioned the storytelling, asking like, what is your story? Because the way I like to summarize all of this is to say, within the constraints of their diagnosis, we guide patients to write their own story, and we use our tools to help make it a reality. And it's really embracing all of the tools that are present that's so nice, in the healthcare system. And it's really lovely. I think it's a big holistic way. It's not just when they're really sick or at end of life. And I think this is care that everyone should receive. So how does this apply to LCC? I'm lucky enough to meet the patients that we see in White Matter Clinic really soon after diagnosis, just to introduce myself. So they might not have very many medical needs at that time, but you're okay. No, you're good. But it helps normalize my involvement. And I think it helps me build a longitudinal relationship with the families and learn what's important to them. Because so much of this has to do with, as Ms. Mahoney said, as everyone has been saying, so much of the care for LCC is individual, and that's the beauty of it. And so what's important to families includes your values, support system, family structure, spirituality, coping strategies that helps you navigate the healthcare system in general. And when I first meet families, typically our colleagues at White Matter Clinic, neurology, genetics, physical medicine, general peds, they're taking a much more active role in day-to-day management, but I can help and support in different ways, and I'll go through what that looks like. This is super high level, and we've learned so much about all sorts of different details of this. So this is a big picture. So the most concrete thing for many people to think about is symptom management and supportive care. So if you have cysts, white matter changes, the blood vessel changes, calcifications in the brain, that can lead to challenges with many symptoms. So we've talked about cognition and behavior, strength, coordination, mobility, sleep, seizures, vision, feeding, secretions, and drooling. Other ones that you're more familiar with than I am, but this is an example. And with these symptoms, they're managed with a whole slew of interventions, right? So we have supportive care, but what does supportive care mean? Medication, equipment, therapies, surgery, behavioral changes, lifestyle changes. And sometimes we don't have to do an intervention. It's just reassurance and acceptance that if it's not bothering you in your life, it's okay to just live with it. And so there's so many different ways to treat these symptoms. How do we choose how to move forward, right? Like how does a patient and a parent and a set of parents, how do they decide? And so the right treatment plan is sometimes really straightforward, that we know that with your symptoms, with your seizure type, this is the medication that works most of the time. And so that's what we're going to try, right? There's not always decisions to be made, but sometimes there are. And for many of the symptoms, the best treatment plan is dependent on so many things: your goals, your values, your supports, lifestyle, practical limitations, like what the school will support, what your home looks like. Do you live in a townhome or do you live in a ranch style home? Do you have the money for a chairlift? Like all of those different things determine what the treatment is going to be. So this is where the physical, emotional, social, and spiritual elements come in as well. Even things like treating salivation and drooling. Some kids are really bothered by it because it's embarrassing in school. And some kids say, I'd rather not take the medication because it dries my mouth. Some have rashes that come from it, and some it makes no difference. And so that's a more simple example, but it's a very tangible one. And so why are values important to treatment? LCC, as we've talked about, is a progressive disease. It has an uncertain disease course with an incredibly variable prognosis. And as of right now, they're only experimental therapies to target the disease. And those are in such early stages, right? So there's not always a clear standard of care for the disease itself, but also for individual symptoms. And caregivers often need to make challenging decisions to weigh things out. So for some families, they like to make those decisions on their own. For others, a palliative care specialist who gets to know you and how you define quality of life and what's important to you can help you figure out the path forward that makes the most sense. And so this is in the setting of helping to navigate in the prognostic uncertainty, as one of our specialties is helping to determine patient prognosis and working with our colleagues to figure that out. So the examples I can think of are like choosing whether to do drooling and secretions, to deciding whether to pursue a feeding tube, to having a VP shunt placed or getting a VNS surgery, or even deciding whether or not to pursue experimental therapies, because there are risks and benefits associated with all of them. And then later on, as children or adults get sicker or older, it can include advanced care planning, discussing code status, surrogate decision makers, guardianship, supported decision making, depending on the child's ability to make those decisions, and then what's important near the end of life. Oh, there's my quality of life bubble. And it was just a really personal decision based on your values and what's important and what you're comfortable with as a family. It also goes to the clinical status of your child goes into it, their quality of life, and all sorts of other things. Okay, so we've spoken a bit about symptom management, communication, and decision making. One of the last big components of palliative care is the psychosocial support, both for the patient and their family. And I think it's really important to be clear about that patient and family have different needs because they are individual human beings, and different family members also have different needs. Many have mentioned here the emotional roller coaster of having the diagnosis, not living with your child, but living while taking care of a child and helping them navigate complicated illness with prognostic uncertainty. And the grief that experience that is so real, the grief that comes from knowing your child will have a life that's different from the one you initially expected and wanted for them. But the support we can just look like listening and validating, identifying resources that can be helpful, and connecting with online resources, connecting with support groups, pastoral services. I do a very thorough history, learning about coping strategies, sources of strength, spiritual history and background, and then finding ways to connect with resources to help support in those ways. Many palliative care teams have social workers or chaplains. They can provide connections with financial resources, even our trained therapists. Some have psychologists. And then, or child life specialists for children, siblings especially, and we can connect with siblings and other family members to help make sense of everything that their children are going through. I'm a little biased. So should you connect with palliative care? I'm a little biased, and I work in an institution that has me embedded in a white matter clinic for patients with LCC. So it's not the case everywhere, though there is a kind of national push for patients with white matter diseases to have early access to palliative care. There just aren't that many of us, both in the pediatric and adult realm. So later referrals are the only option. And especially in the adult setting, oftentimes later referrals are the only option. But it's possible to advocate and see what's possible. So ask your medical team. They might not have thought about it, even though it could be very appropriate. And you could visit a palliative care team in different ways. Some have their own clinics, some can come down to a clinic, some can do telehealth, or some can just see them if they're admitted to the hospital. If it's a well-resourced palliative care team, we're usually pretty good at creative problem solving to improve quality of life in different ways that people don't always think about. We pride ourselves on being good listeners and supporting families. We often have more time than other clinicians do to focus on this level of support. Not to say that they're not as good at listening or doing any of those things, but we just have more time to do it. So practically it's easier. And our job is really to advocate for you so the medical care you receive is in line with your goals and values. Even if early palliative care is not available, ask about other resources in the medical setting that can offer support so that, like we tend to talk about social work, child life, expressive therapies, pet therapy. In pediatrics, we often don't have like activity coordinators. This is a picture of a little girl in our healing garden at Children's National. Many different hospitals have settings just to and programming for patients, even if it's not as obvious. And again, that goes into the building community and promoting quality of life. And not every resource will be available or the best fit for each family, but it's important to explore them. And then, as you have already done, make sure to connect with national, international resources. You're already connected with the LCC Foundation by virtue of being here. I, especially for children, young adults, and adolescents, I'm a big fan of the Courageous Parents Network and NeuroJourney, just to offer resources for helping to just navigate the whole process and the uncertainty. Really, the purpose of everything is to empower patients and families to make the best decisions for themselves and have the best quality of life possible. We did it. Okay. Thank you so much for listening and for having me. And I don't have an acknowledgement slide. Oh, I forgot. No disclosures. And for having, honestly, for the White Matter Clinic team for welcoming me into their clinic 2.5 years ago. It's just been a delight. And also to the LCC Foundation for inviting me. Ooh, goodness. So I'll take any questions.
Thank you. So you touched base a little bit about the quality of life and the therapies that we want to move forward with our kids. We never experienced with the Children's Hospital in DC, but we moved a lot. And there were times that we had to say no for some of the therapies that the doctors wanted us to have. Of course, their intentions were very good, but sometimes we had to make those choices for the quality of the life, and we had to choose our battles to take your kid to the doctor every other week. And we often made feel like we were making the wrong decision.
Yeah.
How do you battle that?
I
mean, that conflict of that decision, right? It's not an easy decision. And as a parent, you feel guilty making that decision, saying no to a therapy, knowing that you're prioritizing basically.
Yeah.
But that, I don't know how to say this, but sometimes we know our kids and I know the intentions are good, but what can we do to work with the clinicians that we are working with to make them understand that we are making the right
decision? Yeah. I want to say I'm not surprised. Oftentimes we as clinicians, and not to say anything bad about any of my colleagues, but we as clinicians, we get very single-minded about what is the best thing for a child. And that's what I talk about. Sometimes there is a clear recommendation. Sometimes there is a very clear standard of care. But sometimes there's not, right? Even I'm just thinking about, I was going to say you give antibiotics for an ear infection, but it's recently changed since I've been in residency. Sometimes you can say, oh, I wait to see if the infection actually needs antibiotics. And if it doesn't get better, then we give the antibiotics, right? So we can be speaking for many clinicians, I think we can be very set in our ways when it comes to what should be done and what's best for a child. And I think sometimes it is true. Sometimes there is a standard of care that really needs to be done. But much of the time, especially with children with a progressive neurological rare disease for which the prognosis is so uncertain, there isn't a standard of care. And so there is room for parental authority. We talk about in medical ethics, we talk about the zone of parental discretion. So there's 5 sections. We're kind of in the weeds here, and I think this is a way to help justify. I don't know if you can pull up the IPO framework to your clinician, but there's things that are impermissible. So you cannot do this for your child, right? These are things that would warrant medical child abuse or neglect, or you cannot make those decisions. There are things that are obligatory, like if your otherwise healthy child gets a very treatable cancer, you cannot give them chemotherapy, right? That almost every medical ethics is you have to give them the chemotherapy and treat their cancer, right? And then there's the zone of parental discretion, or the permissible area. And there are things that we recommend and that we don't recommend. And we're kind of like, something wishy-washy on. And so many things that I'm like mentioning here, the way we treat our symptoms, the way whether you choose to do therapies or not, whether you choose an experimental therapy, all of that is in that permissible. You can choose to do it, you cannot choose to do it. If you go and do a therapy every 2 weeks and you're driving multiple hours and your child's in a wheelchair and you have to take their feeds and they might be on a ventilator, like all of those things, then you have to take off of work. Your other child has to experience X, Y, or Z thing. Maybe your child doesn't like going to the hospital and it affects their quality of life, and maybe it'll help one of their symptoms, but man, they're miserable for the rest of the week and it's just not worth it. And I think, I don't know how to argue, it depends on your physician. And I think one of the things that a palliative physician can do is advocate for what your goals and help you tease out very concretely what the pros and cons are of that and weigh those things and help you, I think, help put wording to that. But I think finding someone, even if you don't have palliative care, finding someone to help you tease out and put wording. It's like, hey man, these things, I understand where you're coming from, but this is what's important to us. And this is why this therapy just doesn't fit that. And if they're like, actually, we can mitigate it and make it better and actually make it work, then that can facilitate a conversation. Yeah, of course.